The present lecture is devoted to the disorders of different layers of the heart and their complications, the valve defects. Here you see the different layers, the interior endocardium, myocardium, and pericardium. Let's now start with the interior of the heart, the endocardial disorders. The most common endocardial disorder is an inflammatory disorder, the endocarditis. Endocarditis are usually infectious and less commonly non-infectious. They are characterized by endocardial lesions, including the valve cusps. Let us now discuss as an example the infectious endocarditis. First, the etiology of the infectious endocarditis. It is caused most commonly by infective agents such as gram-positive bacteria, mainly streptococci and staphylococci in more than 80% of the cases, usually Streptococcus viridans or Beta-Streptococcus and Streptococcus aureus, and less commonly by Enterococci or Streptococcus epididymis, especially in cases due to prostatic valve presence and infective endocarditis, and only rarely gram-negative bacteria and fungi are causing infective endocarditis. The infective agents cause inflammation of the interior of the heart, involving both the valves and also the endocardial surface, and less commonly endarteritis, extracardial endothelium inflammatory events may be observed. Three main groups of factors play a role in the pathogenesis of the infective endocarditis: predisposing states, bacteremia, and the patient's individual resistance. The predisposing factors are damaging the endothelium, either directly, less commonly, or by means of hemodynamic changes into the heart. Thus, pressure gradient may be generated because of our comparatively narrow orifice separating the two chambers, or an abnormal communication creating a flow from a high to low pressure chamber, for example in septum defects. The presence of pressure gradient will generate a high velocity jet stream and create a turbulent blood flow able to damage the endothelium. Thus, endothelial lesions will be formed on the surface of the valve in the lower pressure cardiac area or chamber, or where the jet stream strikes the endothelial wall. Later, fibrin and thrombocytes will be deposited on the damaged area, thus creating the picture of sterile vegetation or bacterial, non-bacterial endocarditis. This is the non-bacterial thrombotic endocarditis. The next factor, this is the bacteremia, the presence of circulating bacteria, as shown here, streptococci in the blood. Bacteria will be deposited on the sterile vegetation during the course of bacteremia. And let me note, there is an exception. It is known that the Staphylococcus aureus can infect even a non-damaged endothelium. It is extremely virulent. Thus, the combination of hemodynamic change and sterile damage together with bacteremia will create deposition of microorganisms and growth and enlargement of infected vegetation. This is shown on the next step here. growth and enlargement of the infected vegetation and activation of an inflammatory process on the surface. The infected vegetation will continue to grow during the duration of the bacteremia. Thus, long-term treatment will be necessary, several 4, 5 to 6 weeks, for effective treatment with antibiotics of the infected vegetation. The excessive growth of vegetation may cause sometimes a necessity for surgical elimination of the vegetations. This slide illustrates an extreme growth and infected vegetation on a cusp of a valve in the endocardium. The long-term bacteremia, the persistent bacteremia, will cause stimulation of the immune system. Both the humoral and cell-mediated human immune responses will be activated. Thus, the formation of immune complexes will be followed by immune complex deposition. For example, into the kidney, the renal glomerular basement membrane deposition will cause eventually glomerulonephritis and later even renal failure. In the skin, the deposition are known as osseous nodes or osseous lesions, usually on the pads of the fingers. They are painful, but also they are observed at other areas, and they may be numerous in severe cases of severe endocarditis with long-term bacteremia. In these patients, an increased serum level of rheumatoid factor is also observed together with hypergamma-globulinemia. The clinical manifestation of the endocarditis may be acute, chronic, or subacute. The hemodynamic changes result from valvular damage and also organ damage from the septic emboli. Septic emboli may be formed from the infected and growing vegetation. Right-sided emboli will be deposited in lungs, while left-sided emboli will be deposited into the brain, spleen, kidney, gastrointestinal tract, and extremities. Thus, organ damage will be produced in severe cases by the immune complex deposition, and also the persistent bacteremia may cause distal seeding of infections, abscesses throughout the body. As a complication, valve affection, severe valve affection till rupture may be observed and to cause hemodynamic collapse, and the bacteremia, if not treated adequately, will evolve to sepsis. Endocarditis is also observed as a demonstration of the rheumatic heart disease, the rheumatic fever. This is an acute, immune-mediated, multisystem inflammatory disease that follows a group A, beta-hemolytic streptococcal infection. It is observed usually in children, especially school-aged children, in the case of genetic predispositions. Usually these children are carriers of LHA, DR2 or DR4 genes. In these children, rheumatic heart disease is observed, usually involving all layers of the heart, the endocardium, myocardium, and pericardium, together with peripheral structure, such as joint, skin, and eventually the nervous system, because of formation of deposition of streptococci and inflammatory damage to connective as well as to the heart tissue. Endocarditis will produce it with affection of the valves, mainly mitral and aortic valves, and valve defect, eventually causing complications such as heart failure. The major complications of the endocarditis, the valve defects, will be especially discussed a little bit later. The next disorder to be discussed, this is the myocarditis. It represents of inflammation of the muscular walls of the heart together with the septum containing the conduction system with complex origin. However, the most common cause are infections, and much rarer, less commonly, non-infective agents are responsible. The infective agents are mainly viruses, especially Coxsackie viruses, B and A, also influenza virus, ECHO virus, poliomyelitis, enteroviruses, and less commonly bacteria, Streptococci, as for example in rheumatic heart disease. Less commonly, non-infective agents such as radiation, heavy metals, toxins, and venoms, scorpion bites or snake bites, some drugs, cocaine, and some treatment, for example, doxorubicin, high doses, or cyclophosphamide may also cause myocarditis. In a typical case, as shown on the picture, the myocardium is attacked by a virus, viral infection, together with other factors already mentioned. Inflammatory response of the myocardium will be caused. Degeneration and necrosis of cardiomyocytes and dilation of the heart, and when progressing, even fibrosis. Viral myocarditis as well as streptococcal pneumocarditis are characterized by the presence of autoimmune reactions triggered by the initial damage and the release of autoantigens by the damaged cells. The inflammatory response into the myocardium, as we know, this is the characteristic of the inflammation, loss of function will cause progressively myocardial dysfunction. The outcome of the disorder, here the picture of the first 4 days to 1 week is presented. The viral infection causing initial necrosis of cardiomyocytes, later activation of inflammatory process with release of inflammatory mediators, and the progression, if not treated of course, to first subacute myocarditis within several weeks and later to a chronic myocarditis characterized by the characteristics of the chronic inflammatory response, especially fibrosis, loss of the properties of the muscle, of the musculature of the heart with cardiac dilatation and eventually heart failure. Let me note that the macrophages, mononuclear cell, will replace the release of cytokines by inflammatory cells during the chronic inflammation. Polynuclear cells will be replaced by mononuclear cells during the transition to subacute and later to acute myocarditis. This slide illustrates the myocardial tissue, the cardiomyocytes, and the infiltration, the huge infiltration by inflammatory cells. This is a picture of acute myocarditis. The myocardial damage is characterized by a decrease in the contractility and decreased stroke volume and heart output, and eventually later dilatation, thus progressing to dilated cardiomyopathy. This is a severe complication in myocarditis, producing heart failure, especially congestion into the lungs, congestive heart failure. Clinical signs include low-grade fever and malaise, decreased heart output due to the decreased stroke volume, and compensatory tachycardia. Arrhythmias are observed in severe cases, and also complications such as dilated cardiomyopathy, as already noted, and heart failure till sudden death. Laboratory findings demonstrate elevated serum creatine kinase very often, and also troponin may be elevated due to myocardial cell damage. Pericardial disorders demonstrate mainly as inflammatory disorders, but also accumulation of an abnormal amount of fluid may be produced into the pericardial space, an effusion or a tamponade. The acute pericarditis is most commonly due to infections, especially viral infections, Coxsackie A virus or influenza, among others. Also, bacterial infections such as tuberculosis infections, staphylococci, pneumococci. They are causing usually a purulent, severe infection. Protozoal infections, amebiasis, may also cause pericarditis. Mycotic actinomycosis, coccidioidomycosis, and also collagen vascular diseases, especially systemic lupus erythematosus and rheumatoid arthritis. Tumors, local tumors, mesothelioma or sarcoma, and also metastatic tumors may also cause pericarditis. Severe metabolic disorders, for example in renal failure, the uremia, in gout also may cause an inflammatory response in the pericardial space. An injury due, for example, to the myocardial infarction into the myocardium, surgical trauma, or radiation also produce pericarditis. And finally, there is an idiopathic form. The cause is not yet elucidated. The pathologic changes include signs of inflammation, increased vascularity, polymorphonuclear leukocytic infiltration, fibrin deposition, and especially exudate formation. The exudate formation and deposition into the pericardial space is shown on this picture. The less severe form of the acute pericarditis, this is the serous inflammation. Usually 50 to 200 milliliters of slowly accumulating exudate are observed. The serofibrinols, the more severe form, this is the most common form. The accumulation is stronger and it may result in fibrin deposition and adhesions of the two sheets of the pericardium. The purulent pericarditis represents an accumulation of 400 to 500 milliliters of exudate, especially pus. It is accompanied by fever and may produce complications in the adjacent area such as mediastinitis or pericarditis. And the most severe form observed in tuberculosis, this is the hemorrhagic pericarditis or the pericarditis observed in malignancy. These types of exudate may organize later with calcifications. In tuberculosis, caseous exudation is observed. All severe form of pericarditis will end by formation of a fibrocalcification and constriction pericarditis form. The chronic pericarditis is characterized by pericardial fibrosis. Now the clinical manifestations. There is a severe chest pain. The chest pain demonstrates a sharp retrosternal onset with radiation to the back. It worsens with deep breathing or coughing, and very often the chest pain is position dependent. It worsens when lying flat. At auscultation, a huge friction rub is observed. Usually it demonstrates, the friction rub, three components: one systolic, related to the ventricular contraction, and two diastolic components. An early diastolic component, due to the rapid filling of the ventricle, and a later diastolic component, due to the atrial contraction. The latter two diastolic components very often may merge in one rib. Also, signs of constrictions may be present. For example, at auscultation, a distinct diastolic knock because of the sudden cessation of the filling due to the accumulation of fluid into the pericardial space. Also, very common, increased jugular vein pressure. The flow entering the heart is limited. In addition, hepatomegaly is also often observed, and even ascites, an accumulation of fluid into the peritoneal cavity with increase of the abdominal girth. Another sign of constriction is observed when recording the atrial pressure. This picture shows a simultaneous record of the brachial artery pressure and the right artery pressure. It is clearly seen the increased right atrial pressure on inspiration. This is a clear sign of constriction. We'll now consider the pericardial effusion and tamponade. The effusion, this is the accumulation of fluid developing slowly, and it may be asymptomatic, at least at the beginning. The tamponade represents a sudden filling of the pericardial space with fluid. This accumulation of fluid will limit the ventricular filling. This slide illustrates a huge pericardial effusion. As you can see, it is clearly greater the amount of the fluid accumulating as compared with the acute pericarditis. Meanwhile, the most common cause of the effusion, this is a long-lasting and progressing pericarditis. The functional changes result from the increase of the interpericardial pressure, at times to the level of right atrial and right ventricular pressure. Thus, collapse of the chamber may be caused, collapse of the atria, thus to prevent the appropriate filling of the heart. The clinical picture of the pericardial effusion is dominated by three signs, a triad known as the triad of Beck. The Beck's triad includes hypotension. Hypotension is due to the decreased cardiac output because of the limited filling of the heart due to the accumulation of the fluid into the pericardial space. Second sign, this is the increased jugular venous pressure. And third, the muffled heart sounds and auscultation, or even indistinct heart sounds, again due to the massive accumulation of fluid into the pericardial sac. In addition, the so-called paradoxic pulse is observed. It is demonstrated by a marked inspiratory drop into the systolic arterial pressure. It is shown on this record. Inspiratory drop of the systolic arterial pressure. The mechanism of the inspiratory changes, the paradoxic pulse during inspiration, is demonstrated on this picture. As the filling of the right ventricle is increased during inspiration, this will cause an interventricular septum here, so to bow to the left and to decrease the left ventricle volume. This is the so-called reverse Bernheim effect. The decreased left ventricular filling is responsible for the marked decrease inspiratory drop in systolic arterial pressure. The filling of the left ventricle is also decreased by the decreased flow into the left atrium from the pulmonary veins during the inspiration. Thus, a decrease of the stroke volume, heart output, and the atrial pressure and systolic ventricular pressure are observed. And finally, the decreased heart output due to the restricted filling may cause in some patients accumulation of fluid congestion into the pulmonary veins, pulmonary edema, demonstrated by shortness of breath, dyspnea. Let's now consider the valve defects. As already mentioned, they are usually the most common complication of endocarditis, among other causes. The valve defects are known to cause hemodynamic changes due either to a narrowing of the valve orifice, this is the stenosis, or to the incomplete closure of the valve cusps, this is the valve incompetence or the valve insufficiency. In a lot of cases, both stenosis and insufficiency are observed into the same N1 valve. We will now characterize pure defects, either stenosis or insufficiency. Let us start with the aortic stenosis. The etiology of the aortic stenosis is illustrated on the slide. In children, the cause is mainly congenital. In adults, the cause is mainly degenerative and also inflammatory change. Inflammatory changes, especially endocarditis, are involved. The inflammatory changes are the most common cause of aortic stenosis in adults. Normally, the area of the opening of the aortic valve is about 3.5 to 4 centimeters square. The full-blown picture, clinical signs of aortic stenosis are present in a case in which the area is below 0.8 to 1 centimeter square. This picture illustrates the structure and functional changes in aortic stenosis. It may demonstrate either a tricuspid valve with severe thickening and stenosis or bicuspid aortic valve, as already shown to be the case previously. The bicuspid valve is an important cause for the disorder. As a consequence, functional changes are observed. Look here. This is especially the phonocardiogram. Let me to draw your attention. Acoustic phenomena are recorded. This noise recorded is known as murmur. The murmurs are characterizing the acoustic findings in valve defects. Let's now comment the functional changes. A narrowing of the aortic valve. Thus, an increased afterload for the left ventricle is present. As you can see, an adaptive response is present. Hypertrophy of the left ventricle walls, a huge hypertrophy. And this hypertrophy is concentric. It's advancing to the center of the cavity. So finally, the cavity volume, the left ventricle volume, is decreased due to the huge hypertrophy of the ventricular musculature. The significant thickening of the wall will decrease significantly the ventricular compliance, thus it will embarrass the filling during the diastole. During the systole, the flow through the narrowed valve will cause vibration due to the creation of turbulent flow through the valve, and the vibration will generate acoustic phenomena known as murmur. Here, this is the systolic murmur recorded in aortic stenosis. The progression of events is illustrated on this picture, especially for the severe aortic stenosis. Because of the increased afterload, left ventricular hypertrophy, because of the increased afterload, and the ventricle hypertrophy will cause the left diastolic dysfunction because of the decreased compliance, the increased thickness of the lobe. The increased afterload with the progression will cause an afterload mismatch and abnormal systolic pump function, which together with the diastolic dysfunction may end when progressing in clinical heart failure. Let's now summarize the changes in severe aortic stenosis. First, due to the increased afterload, left ventricular muscle mass is increasing, hypertrophy. The contraction of the hypertrophied ventricle will cause increase of the left ventricular systolic pressure, and as a consequence, increased left ventricular and diastolic pressure. The systolic ejection time will be prolonged because of the increased afterload. All this work will generate an increased oxygen need. Thus, a relative myocardial ischemia will be generated into the left ventricle. However, in addition, there is a reduced coronary perfusion pressure. This coronary perfusion pressure decrease, which is potentiated by the compression of the coronary arteries, by the huge contraction of the ventricle, will cause a reduction in coronary blood flow. This will cause already an absolute myocardial ischemia. The ischemia is potentiated by the intramyocardial coronary arteries compression. Consecutively, it is at every bit potentiated. So, myocardial ischemia is an important functional change in severe aortic stenosis. Thus, ischemic events, angina pectoris, because of the increased oxygen demands and the decreased coronary blood flow, are present in about 50% of the patients. You'll consider within details the coronary artery disease the next week. So, this may progress till to a congestive heart failure with increased pulmonary venous pressure, edema, and dyspnea. The physical examination of a patient with aortic stenosis will reveal, as already mentioned, a murmur, a mid-systolic murmur, crescendo, decrescendo, increasing, decreasing. This is the mid-systolic murmur on the base of the heart. Another finding is the prominent S4. The sound 4, a fourth heart sound, is very often recorded. This is due to the atrial contraction against the increased end diastolic volume of the left ventricle, increased end diastolic pressure, especially into the left ventricle. Finally, a long-term progression of this condition will produce a hypertrophic cardiomyopathy, hypertrophy including the left ventricle and also the septum. This condition is characterized by a decreased left end diastolic volume, decreased stroke volume, decreased heart output, hypotension, and syncopes. The next defect, this is the aortic regurgitation or the aortic insufficiency. It may present either as acute or chronic, with or without compensatory mechanisms. This defect is most commonly due to an inflammatory process, endocarditis, for example pneumocarditis, or to inherited anomalies. Another group of less common change include aortic changes, for example mesortitis luetica, or dilation of the aorta in hypertension, or genetic disorders of the connective tissue, for example Marfan syndrome or osteogenesis imperfecta. In aortic insufficiency, because of the incomplete closure of the aortic valve during the diastole, the left ventricle is filled both through the aorta and through the left atrium. This will cause a diastolic overload, a volume overload of the left ventricle. The overload is followed by a compensatory hypertrophy. However, this hypertrophy is eccentric due to the increased filling to the increased volume load of the left ventricle. Eccentric hypertrophy, not concentric as observed in stenosis. Because of the increased end diastolic volume, the stroke volume will be also increased. Look here, the phonocardiogram demonstrates a record of these changes. The increased flow due to the increased stroke volume through the systole will generate a systolic murmur, crescendo, decrescendo, while the regurgitation during diastole will cause a diastolic murmur. So, in aortic insufficiency, both systolic and diastolic murmurs are present. The outcome of this disorder, especially the severe chronic aortic regurgitation, include an increase of the volume because of regurgitant volume, left ventricular dilatation plus left ventricular hypertrophy, and left ventricular systolic hypertension. So, this will alter the left ventricular diastolic pressure to volume relationship and to cause gradually left ventricular diastolic dysfunction, together with the increasing afterload, and as a consequence afterload mismatch, and finally abnormal left ventricular systolic pump function, especially due to the dilatation. These are predispositions of a clinical heart failure to be generated. Let's now summarize the events in chronic aortic regurgitation. First, because of the regurgitation, increased left ventricular diastolic volume. This will cause increase in the left ventricular systolic volume due to the contraction of hypertrophied musculature of the left ventricle. This is the consequence, increased left ventricular muscle mass. The systolic pressure into the left ventricle is also increased, and finally even the end diastolic pressure is increased. Due to the increased volume, the systolic ejection time is prolonged. All these activities will increase the oxygen demands. Thus, relative myocardial ischemia will be present, and against a reduced coronary perfusion pressure, together with the compression of intramyocardial coronary arteries by the hypertrophied muscle, will cause a reduced coronary flow reserve and an absolute myocardial ischemia. These are the events in chronic aortic regurgitation severe form. Now let's comment the clinical signs of the aortic insufficiency. At physical examination, hyperdynamic pulses are found. In other words, widened pulse pressure. It is illustrated here. An increase of the pulse pressure, high systolic against a normal or very slightly increased diastolic. The palpation of the peripheral pulse will reveal a water hammer-like pulse. The pulsations are visible. They are present even in the uvula, in the nail beds, and even hair bobbing is observed in some patients. As already mentioned, murmurs are present. The genesis of the diastolic murmur is complex. The early section of the diastolic murmur is due to the regurgitation, while the late section is due to a brief functional stenosis of the mitral valve due to the compression of cusps of the mitral valve by the regurgitant flow from the aortic valve. The systolic murmur, crescendo-decrescendo, is due to the increased stroke volume due to the hypertrophy of the left ventricle wall. A third heart sound is also often present. It is due to diastolic filling, early increase of the diastolic filling, or later to the heart failure, especially to diastolic dysfunction. Because of the significant hypertrophy of the left ventricle, let me remind, it is eccentric, the apical impulse is displaced to the left laterally. The progress of the severe aortic regurgitation to clinically heart failure is accompanied by the elevation of the hydrostatic pressure into the pulmonary circulation, lung edema, and dyspnea, demonstrated by shortness of breath. Now, let's go to the mitral valve. We'll consider first the mitral stenosis, the narrowing of the mitral orifice. Normally, the area when opened is about 5 to 6 centimeters square. If decreased to about 1 centimeter square, clinically relevant picture will be produced. So, sixth, normally 1 centimeter square, the decrease, this is the borderline, the crucial decrease. Most commonly, this is a complication of rheumatic heart disease, especially the endocarditis, less commonly congenital or calcium depositions, calcifications due to some systemic disease, for example, rheumatoid arthritis or lupus erythematosus. The stenosis, the narrowing of the mitral valve, causes decreased filling of the left ventricle and, as a consequence, decreased stroke volume and decreased heart output. However, the volume will be retained into the atrium, thus to cause increased left atrial pressures. Left atrium will be enlarged and finally thickened. This is very well presented on the picture. The increased left arterial pressure will be transmitted to the venous circulation of the lungs, thus to produce increased pulmonary intravascular pressure, and also right-sided pressures. Pressure in the pulmonary artery, right ventricle, and right atrium also will be increased. The increase of the intravascular pulmonary venous pressure is followed by filtration of fluid into the interstitial space of the lungs, lung edema causing dyspnea, and especially the increased hydrostatic pressure in some patients may cause rupture of small vessels, so bloody sputums may be present as hemoptysis in some patients. In summary, the decreased heart output together with the lung congestion and the lung edema are the signs of occurring left heart failure. This is a typical outcome of the mitral stenosis. The lung edema, as already mentioned, is responsible for the dyspnea, manifesting as orthopnea and the shortness of breath together with the hemoptysis. The huge dilatation of the left atrium will cause damage to the cardiomyocytes and thus to generate tachyarrhythmia due to a re-entry mechanism generation. It is sensed by the patient as palpitation, a tachyarrhythmia, supraventricular atrial tachyarrhythmia due to the damage of cardiomyocytes into dilated left atrium. Other signs may result from the enlargement of the left atrium. For example, the enlarged atrium may impinge on the recurrent laryngeal nerve. Thus, it may cause some hoarseness. The enlargement will cause, especially after dilatation, a slowing of the blood flow. Here, this is a precondition from thrombosis and generation of emboli. Embolic events will be present in about 20% of patients with atrial dilatation due to mitral stenosis. From the physical examination, let me note the auscultatory findings, especially the diastolic finding. The murmur registered is diastolic. First, a brief opening snap is recorded, followed by a murmur because of the turbulent flow through the narrowed orifice of the mitral valve. Let's now summarize the mechanism and the signs of the mitral stenosis. First, the decreased filling of the left ventricle, causing reduced left heart output because of the reduced stroke volume, reduced tissue perfusion, and demonstration of weakness and fatigue in the patient. The left atrial congestion and increased pressure will cause pulmonary congestion, hypertension, pulmonary edema with dyspnea and reduced respiratory function, and probably as a complication, bronchopneumonia may occur. Increased right heart workload, also because of the increased pressure in the pulmonary circulation, with right heart failure that may follow the left heart failure. This will cause peripheral edema with hepato and splenomegaly. This is the picture of full-blown complicated mitral stenosis causing heart failure. Now, the last valve defect to discuss, the mitral regurgitation. The regurgitation, the insufficiency, results from a rupture of the chordae tendineae or a damage to the papillary muscles as a consequence of inflammatory change due most commonly to an infection. Less commonly, degenerative changes or congenital changes may be present. The mitral insufficiency is the most common valve defect. Because of the incomplete closure of the valve cusps, there is a return back of blood back to the atrium because of the pressure gradient during the ventricular systole. Regurgitation is generated in that way. the left atrium is overfilled with blood, enlarged, dilated, and the hydrostatic pressure of the blood is increased. This increased hydrostatic pressure is transmitted to the venous vessels into the lung venous circulation, thus causing generation of edema, ultrafiltration of fluid into the interstitial space of the lungs, pulmonary edema. In addition, due to the increased volume of the blood into the atrium, the filling of the left ventricle is increased. The end diastolic volume in the left ventricle will be increased, thus to cause hypertrophy and enlargement of the left ventricle also. The stroke volume of the hypertrophied ventricle will be also increased. However, because of the regurgitation, the increased stroke volume of the left ventricle will be combined with a decreased heart output to the systemic circulation because, I will repeat, of the regurgitation of the blood back to the left atrium. The physical examination of a patient with mitral insufficiency reveals presence of the hollow systolic murmur generated by the flow through the regurgitant valve and the powerful contraction of the hypertrophied left ventricle. The hollow systolic murmur occupies the whole space, the whole time between the heart sound, and eventually a third heart sound will be present if a heart failure is already occurred or if a severe regurgitation is present. Also, the apical impulse will be displaced to the left because of the hypertrophy of the left ventricle. Due to the dilatation of the left atrium, palpitations will be also present as observed in mitral stenosis, and a risk for thromboembolism is also present in these patients. The congestive heart failure generated by this condition will cause pulmonary edema with shortness of breath, orthopnea, and especially paroxysmal nocturnal dyspnea because of the increased pulmonary capillary pressure, increasing especially by night when laying down, when laying supine. The increased output from the heart because of the regurgitation to the left atrium will cause fatigue and weakness in this patient. Complications that may occur include embolization because of thromboembolism in the dilated atrium, and also because of the damage to cardiomyocytes, tachyarrhythmia, palpitation sensed by the patient, and flutter or fibrillation with complication, even death may occur.